Hello and welcome once again. For those of you who have been with us all day, we really do appreciate you taking the time. This session is a very special session because we have Nancy Morgan with us. And if you haven't heard the name Nancy Morgan, I would be surprised, to be honest. But Nancy is a nationally and internationally recognized leader in wound care education, compliance, and clinical innovation. A proud American Samoan, she leads with the values of faith, family, and service. As executive director of the Academy of Prescribers in Wound Healing and founder of Wound Care Professionals, Nancy advances prescriber competency, regulatory alignment, and defensible documentation while driving national education and compliance standards. She also pioneers AI-supported tools like Wound Coach, which is really cool, by the way. I love it. Providing real-time clinical and compliance support. Nancy co-founded the Wound Care Education Institute, the National Alliance of Wound Care and Ostomy, and the Wild on Wounds Conference, which I'm sure a lot of you attended over the years, which have certified more than 40,000 clinicians and trained over 150,000 professionals worldwide. Holy moly, that is amazing. So we're really lucky to have you here, and I really appreciate you being here. I'm sure everybody's going to learn a ton. I'll field some questions, so if you've got questions, just throw them in the chat, and we'll start rocking and rolling. And I'll let Nancy, without further ado, please go right ahead.
Okay. Thank you so much, Josh. Appreciate it. Welcome, everybody. So today we're going to talk about wound care and lymphedema and how we can come together and serve our patients. I have some pretty slides that are coming up for you. Now, some housekeeping things before we get into the presentation. Those of you will be at the end of today's presentation, I'll have a slide and it'll be a little QR code that you can just take your phone and shoot the QR code and you can fill out an evaluation and it'll ask you for some feedback. Those that want CEs, once you complete the evaluation, your CEs will be emailed to you directly. So this session of mine, I know we have a lot of nurses online, so I do have CEs that are available for nurses for today. All right. So I just need to make this announcement. I just got to get it out of the way because I've been so excited about this for several months. I want to introduce to you the first ever in the world, a wound and lymphatic microcredential. And yes, it does exist. And this is what it's called. It's Wound Lymphatic Integration Specialist. Yes. And what it is, and you'll know, some of you are CLTs, some of you are nurses. And there's a lot of times there's no crossover, like nurses only know so much, CLTs only know so much. But this credential for the wound care people right now, okay, this is for you. I designed it for you. There's 5 different modules. It's a short course. That's why they call it micro, but it's to give you enough information so you're dangerous in the field. So when you see things, you know exactly what you're looking at, how we can get garments for our patients and really make a difference in their life. So these are my 5 little chapters that I made, and it's about the Lymphedema Treatment Act. And I'll talk a little bit about that today, and also about how swelling starts, what's the swollen truth? And then, looking at the whole limb, what matters, what doesn't matter. And then lastly is, what can we do to help our patients? Compression, safety, who do we refer to, and so on. So I just want you to know that this exists and it's going live next month. So you see that little QR code in the upper corner, go ahead and take your phone and you can shoot it. And then once you get on the page, scroll all the way to the bottom and it has like a little blue bar and it says notification. I want you to be the first to know when this goes live because we designed it for you guys. Now, the CLTs that are on the line, I didn't forget about you. I've got stuff going on for you too. At first, I just wanted to do this for the wound care people. And then later on, I've got other things cooking for you. So you're not left out. I got some stuff for you too. All right, so I have to do a disclosure because we're doing continuing education credits, and it's just pretty much letting you know I don't own anything. I'm not paid to speak. I'm here to serve, talk about evidence-based education, and that's really what we're here for today. Okay, so when I present to you, it's always going to be non-biased. I'm going to give you the evidence, and you take it from there. Our objectives, pretty much two objectives that I'm going to focus in and drive home on. Number one is what are the common lymphedema related skin issues that we will run into, both sides, CLTs and nurses. What are those? How can we identify them quickly so we can get some help for our patient? And then lastly, well, I want to apply the Lymphedema Act, okay? I want to talk about that. And that was released in 2024, and it provides coverage, documentation, and requirements to make sure that we're meeting Medicare guidelines, but we can get these garments for our patients because that's who needs them. All right, so those are our objectives. Warning, before we get started, I have to do this because I was doing this presentation in front of other people and I think one just passed out like in his chair. He's like, oh my gosh, Nancy. So I want to give you a heads up. Graphic pictures. It's graphic, but we need to know what we're dealing with. And these are things that are very common in the patients that we are serving. So it's bad. If it's really bad, just close your eyes, wait a few seconds. I'll click the slide and we'll keep moving. Okay. All right. I gave you the warning though. Okay. So here's the real world, guys. This is like, if I could give you the State of the Union, this is exactly what's going on. When you have a lymphedema patient and it shows up, and this patient shows up in your wound care clinic with a wound, what happens? What happens? Think about it. Well, I know what happens. Sorry, we can't help you at the wound care clinic because this is lymphedema. And the wound care clinic doesn't know lymphedema. And so the patient's like, oh no, they can't help me either. So the lymphedema folks sent me to the wound care people so I can get my wound healed, but they can't help me because I have lymphedema. And then the lymphedema people couldn't help me because I had a wound. And so I feel like I've just been tossed back and forth. And that's really what goes on with our patients that have this. Well, those days need to stop because you guys in lymphedema and us in wound care, we really need to come together. And if we can come together, we can really make a difference in our patients' lives. So why is it this way? Why does it separate like this? How come one doesn't know what the other one's doing? Well, this has been going on for a few years. So it's not like it just started, okay? We've been living in two different worlds, guys. I mean, that's just what it is. It's like apples and oranges. Wound care and lymphology. So they're not the same thing, okay? We both focus on different things. But we also have lack of collaboration. There are some wound care people in parts of this United States that don't know a CLT, that doesn't know where they could refer a patient to. And then there's lymphedema people that don't know the wound care people and who they can refer to. So we have this lack of collaboration. We have lack of professional relationships between each other. I just did the numbers. I just did a light look just to see, okay, how many are we dealing with? So the first three guys, okay, in the bullets, those are wound care people, certified wound specialists, wound care certified folks. You got the WOCNs, wound ostomy continent nurses. All three of those people, folks, work in wound care. And then the other two, you've got, over 2,200 that are LANA CLTs. You've got over 1,000 more that are CLTs that are non-LANA. So it's like thinking, oh my gosh, what can we do? Because there's only so many of you guys, so many of us. How can we best serve our patients? Well, I feel that it's important that we come together. So if I took the best of wound care and I took the best of lymphedema and we put it together, this is where we're going to merge our strengths. Yep. So I want to talk to you about the Lymphedema Act. I want to just hit some highlights for you, and because this was released on January 1st, 2024. And so before, okay, for our patients, there was no coverage for lymphedema supplies. There was nothing for them. They had nothing. But now it's different. Now we have coverage that applies to both primary and secondary lymphedema. And that's a good thing. That is a good thing. Absolutely. So when we look at the act, and I just want to give you the highlights of it, what does this act really cover? Well, number one, it defines lymphedema compression treatment. Okay. It defines exactly what those items are. So that's helpful. What are these covered items? Daytime, nighttime compression garments, multi-layer bandaging systems. Some also include the Velcro wrap devices, and then also donning and doffing aids. Donning and doffing might be like foreign words to some nurses because we don't use that as much, but donning means put it on, doffing means take it off, okay? It's just a quick way to remember that. The Act also covers certain body parts, okay? So it's going to cover that particular body part that patient's struggling with, and it will include standard and customized garments. And then lastly, well, orders must be from a licensed prescriber, so physician, NP, and when you are doing the order, that those items must be furnished by a DME that's enrolled in DME POS supplier. You just can't just get it from somebody else. It has to be a specific type of supplier. And they got to be on the up and up too, because we're all kind of in this together.
Absolutely.
So this is just for nurses, okay? And feel free to take any of the pictures. And if you want to take a picture, let me just smile. Okay, there we go. Just strike a pose. So many people need to take pictures of my slides and then they get this weird face of me. So anyway, checklist for nurses. This is what you guys need. Okay, well, we need to make sure that we confirm that we have a patient with diagnosis of lymphedema. That would be very helpful to know that. And we also need to identify, well, what limb is affected? Is it the right? Is it the left? And then also we need to demonstrate medical necessity for these compression garments. We also need to specify if the custom garment is required and the rationale for it. And then if they have a wound, well, we need to make sure that we include everything in regards to the wound assessment. So a description of the wound, the size of the wound, how is it draining, etc. All right, so on this slide, what I wanted to do is just take everything I just said to you and just put it in a nice compliant note. And yes, you can take a picture of this because it's just a nice example. So here we go. Let's just hit it from the top. I'm going to read this. Patient has chronic venous insufficiency. Boom, we check that box, right? Complicated by venous leg ulcer with coexisting chronic secondary, you hear that, guys, lymphedema or the left lower extremity. The limb demonstrates persistent edema consistent with mixed venous lymphatic disease. Do you guys see that word in parentheses? It's called phlebo-lymphedema. That's a hot word right now, okay? Phlebo-lymphedema, and that's exactly what this note is telling the reader. There's a mix of venous and lymphatic together. It's phlebo-lymphedema. Ongoing compression is going to be necessary, medically necessary to maintain the limb volume, manage the lymphatic overload, control the drainage, and promote wound healing to reduce the risk of the ulcer to reoccur. There's a beautiful note, ladies and gentlemen. So that would be an example of just pulling all those factors together. And you guys have a picture of my slides. So you guys have this too. You could take pictures, but you also have access to my slides. All right, so on the CMS side of things, okay, what are they looking at? What are those auditors looking at? So I just wanted to kind of drive home some of the key things. So, all right, well, they're looking for a signed order from the prescriber. That would be a no-brainer, guys, right? I know it sounds elementary, but how many times do suppliers get these empty forms? It's like, oh my gosh, the doc didn't even sign it. No, we need it signed. And then we also need to make sure that the supplier is enrolled in the proper program. So they're a DME, POS group. We need to make sure that the documentation. So if we have a patient that, say, for instance, needs another set of garments or whatever, let's make sure that we are writing proper documentation to justify the replacement of, say, that maybe it was damaged, the garment was damaged, the garment was lost, whatever the case may be. We need to be very clear on our documentation so we can get them another set. We don't want to waste time. We want to make sure that they get a replacement set right away. We're also going to, the auditors are going to look at how often do we need to remeasure this? Is this ongoing? Are we seeing this ongoing in the chart? And then lastly, patient education. What is documented? Is somebody teaching the patient on how to use these garments, how to take care of them, how to launder them, how to replace them. Make sure that we are covering that, because why do we want to give somebody something and they're not educated on how to use it properly? Okay, it's going to defeat our purpose. So these are all key things that we need to make sure that we have in place so we can just get it through the first time. Mm-hmm. All right, so speaking of replacement frequency and how much does things cost for a patient? Okay, CMS allows multiple daytime sets per 6 months. Nighttime garments every 2 years, if medical necessity. Okay, if it's medical necessary. Well, that's why we got to write and document key things. We talked about replacement. Replacement is permitted for any loss, damage, or ill-fitting type garments. And that could be due to maybe there's a limb volume change that is existing in the extremity. So that might prompt a reorder or a replacement of a garment. Now, the patient pays a standard Part B deductible plus the 20% coinsurance. Okay, but it's important that we educate the patient so they're adhering to the program. This is how it's going to roll, Mr. Jones. Da, 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 da. So if they're educated, then that way they won't have confusion.
Yeah, and just to jump in on that too, Nancy,
Yeah,
from
please.
billers, from our perspective, if you're looking at Medicare, because we're talking a lot about Medicare guidelines right here, right?
Mhm.
And so with the LTA, and um, if you back up one slide, I'll
Yeah,
just kind of touch on a
yeah,
couple things there. No, you're
that's
fine. But that the deductible on Medicare, there's a couple things that I want everybody to know here. One, it's really low. I think it's $283 this year. I think it went to 283 or 284 or something like that. It was 257 last year. So they always kind of increase it a little bit. It's usually in the $20 range. But they've brought that up. But most Medicare patients we're talking about will meet their deductible by February. So almost every single one will have that done by now because it's such a low amount. So, oh, thank you, Claudia. Claudia actually chimed in and actually corrected me completely. It's 283. It's not 283 or 284. It's just 283. I was right the first time. Should have just stuck with it. But and then they'll have that coinsurance. However, there will be a lot of times that a Medicare patient will have a secondary insurance, and that secondary, a lot of the times, will cover that 20% coinsurance. And so all of a sudden, you've got a patient that's covered at 100% when they get these garments, and that's an incredible thing. So I just
Mhm.
wanted to kind of touch on that, and then a couple of questions had come in too. One would be a hard copy of the presentation. Absolutely, we have a resources page. I'm going to make sure to post the resource page, and if there's
Mhm.
anything you need, I'll drop my email on here too. You can always reach out to me, and we can make things happen. Uh, so another question, and just all on the same, insurance basis here. Suzanne has had a really hard time finding reimbursement or clinical policies for commercial insurances. And so can we give any guidance on that? Yes, the thing about insurance is that you could say Blue Cross Blue Shield, or you can say Aetna, you can say Cigna, whatever. Those are the big umbrella names for what are massive, massive companies. And if you just look at Blue Cross Blue Shield, there are 60,000 different Blue Cross Blue Shields. So when
Wow.
you say, do you take Blue Cross Blue Shield? Yes, is the answer. But maybe not, could be. If it's one of the 59,999, we got it, right? But it might be
Mhm.
that one, right? Or that one might have a carve out that says, no, we don't cover compression. And that's where those changes are going to be. So there's not really we have a benefit verification team. So when you send us patients, we're going to verify those insurance benefits. And we can tell you that we take Aetna, and we do. But there might be that one policy that it's not covered for whatever reason it is. It might just be a carve out that they're not allowing it in that state, or a carve out that you have to reside in that state. There could be a multitude of reasons that change that. So that's probably why you're having that hard time finding it. But Suzanne, I'll put my email on this presentation here shortly. Feel free to take it down. Shoot me an email. We'll connect offline because I don't want to interrupt Nancy's presentation too long on that. But just so you know. So thank you for letting me interrupt you there, Nancy.
Oh,
I
hey,
appreciate
no,
it.
no problem. I'm not the expert of this, guys. I know enough to be dangerous, but I go to Josh if I need some of these intricate type detail things. So, I can't know it all. So I appreciate that he's there. And then also he can answer a lot of these questions that you might have as I'm going through it. Okay. All right, here we go. So let's see, common coverage pitfalls. So these are just some things, heads up on when we see things being kicked back. Maybe they're just documenting the word edema instead of using the word lymphedema. Okay, that makes sense, right? Unsigned order, we already talked about that. They didn't say it was the left extremity or the right extremity. They didn't even specify what body part. The supplier was not enrolled in the correct with the HCPCS codes. There's no linkage in between the wound and compression documentation. So those are some different common pitfalls that we'll see. The solution is a structured note that meets the CMS audit standards. I mean, that would be the best way to do this so we know we're hitting all the key points. So here's just a quick table. You can take a picture. You'll be in my notes, but this is kind of like what it looks like. So you have daytime garments, the HCPCS codes, how often replacement frequency is set up, and then some key things on documentation on triggers. So of course, if we're talking daytime, we want to make sure that we have a diagnosis in place. We're identifying what limb and then the medical necessity of that particular garment. And we would do the same on all of those. Okay, so there's some detective work that we have to do in order to get things right. So we do have to do some connecting of the dots and putting our little detective hat on and seeing, like what we're doing. So I have to put a little hat on right here. It's my little detective hat. And I need to get nosy when I'm looking at the skin. Okay, so I want to look at every single piece of the skin. What color is it? What is the temperature of it? When I touch the tissue with my gloved hands, what does it feel like on palpation? That's what palpation is. We want to use all our fingers and get that in place. We also, and this is a big deal, because when I was taught wound care and stuff in college as a nurse, I learned off of books and textbooks that had light colored skin. But my patients had dark skin. So a lot of times you'll see me add the dark skin in because people miss that. So if you have somebody that has dark skin tone, like this person up here in this picture, I want you to zoom in on that photo, okay? Look at the darker areas that are darker than the surrounding tissue. Those are areas that we need to be concerned about, that because that's not right. So look for those slight variations of the darkness of color. The darker it is, it's going to trigger you to look, further investigate. Sometimes people call it, it's an eggplant color. That's why I have that image there on the slide. It might have that dark purplish kind of eggplant color, for those of you that know what an eggplant looks like. Some people call it hyperpigmentation, and that would be what you see on that top picture. A little darker in those certain areas, hyperpigmentation. An exaggeration of the color that is present. That's pretty much what that means. Okay, so palpation. This is what us wound care people do. And it's a little infrared, non-contact, so it doesn't touch the patient's skin at all. And what we do is we use it on the limbs, okay? And what it does is it shoots out like a laser, and when it hits if it hits the skin, it will measure a temperature. Okay, so if it's telling us the temperature of the limb, if we have more than 2 to 3 degrees increase, okay, that may signal that we have inflammation going on. Something's going on in the tissue. We need to further investigate. Now, if for some reason we use this and we have a drop in degrees, 2 to 3 drop into degrees, okay, it's colder. Well, colder means that I don't have blood flow. And if I don't have a lot of blood flow, then I don't have nutrition and oxygen going to the site, so I can't heal the wound. So these are important things that wound care people need to know. And that's as simple as just checking the temperature of these limbs. And then we use this non-contact infrared thermometer. Now, where can I get one of these? These look really cool, man. Amazon, Home Depot, they're like $50, 50, $99. And it's kind of like a point and shoot device, and it's wireless. Some of them are wireless. Of course, that's what you would want. And then I just put it in my tool belt. You know what a tool belt is, like a belt that we would wear at work. I just stick it right there. So I'm ready to go. If I have any of my patients with lower extremity wounds, anything from knee down, I am using this right away because it really tells me what's going on with that particular limb. So if you don't have one of these, get one of those. Okay.
Actually, a question did come in about that if temporal thermometer would work for that, or if you need to do the laser.
You've got to, it's not been tested on the temporal because that's different, right? Isn't that the one where we touch the temporal? We don't, on this one, you do not touch. So it's non-touch infrared. So just
I would say that it might work. It might work, but it doesn't seem like I don't know about the only thing that made me worry about that is that you've got a patient with an open wound, and then you use that and you're touching the patient, and then you got
Yeah.
the next patient with an open wound. Yeah, I would. Oh, she said no, this one is the one we have is a point and shoot. So if it's point and shoot, it should work. If it's shooting out a laser and giving you a temperature on the skin, it should work.
He send me a message. I'd like to know what that is because that would be good to know. I'll check the literature. Whatever I'm saying, guys, is whatever the literature, when they did the study, what they use. So right now, I'm just going to say non-contact infrared right now until I can prove myself different and there's something new, and then we can always announce it to you guys. Okay, thanks for the feedback. So
Sure.
we still have our detective hat on. I want you to look at that skin. Look in there, zoom in there. That's dry skin. Okay, dry, flaky, scaly. And they have this word in healthcare called xerosis. It starts with an X, xerosis. And that is when it's just really, really bad. It's so dry to where it can crack the skin. If it's a partial split or a full split, whatever, it's called a fissure. Fissure, that's what it is. Now, since we're friends, guys, when I'm in these long lines during the summer, like at the airport, or maybe I'm at Walmart, I don't know about you guys, but since I'm a skin nurse, I'm checking out everybody's heels, the back of their elbows, behind their ears. I'm always saying, do they got fissures on their heels? And believe it or not, there's a lot of people with fissures on their heels. And I want you to think about that. Zoom in on that fissure, how it's open. When there is a break in the skin, the bacteria move in, ladies and gentlemen. That's what you need to be thinking. And that's what I constantly think at them in these lines. Going, oh my goodness, we need to go protect those feet because that's all that's going to happen. Some bacteria is going to get in there and cause us all kinds of problems. So look for fissures in the community and on your patients. That's the drive home point. All right. Now, sometimes we have skin that is just too wet, okay? And the fancy name for that is maceration. And so when it's too wet, the tissue gets moist and it gets soft. I want you to think about maybe you were in the bathtub too long, okay? And you look at your fingertips and it's like wrinkly and it's raised. That's maceration. That's what's going on with your fingertips. So around wounds, we have too much drainage, which of course, a lot of times with lymphedema, we would, right, guys? So it's now spilling on that tissue. We call it peri-wound. So it's around the wound tissue, peri-wound tissue, and it's macerating. So if we see that, we need to fix that now. Otherwise, this is going to double in size. It'll double in size within like 24 hours if we can't stop this. So this is our way of the body telling us, hey, this is too much drainage. We've got to get the right dressing in place, get the compression in place so we can get control of this. So that's what that is. So that's maceration. Okay, so here we just have these little sites. And, I do this. I'm sure you do this too. I'm looking for swelling. Okay, I'm looking for swelling. And when I see this, I'm looking for edema. Do they have edema? Do they not have edema? Is it on? Sometimes we get it around on our ring fingers, So this is like a little silicone ring. So it expands as I get a little, maybe I have too much salt or whatever. It'll expand as my fingers expand. Sometimes people's rings do that. Sometimes they don't. Sometimes they have different devices on their limbs and it's just choking off the blood supply and the circulation. So when we see this, I want us to look at this, okay, and monitor this. So for instance, if we have this lady, she has these swollen ankles, okay? And this is the first time we saw her. This is what we're gonna do. And this is just something simple. Let's just watch her overnight, elevate these, okay? Let's elevate them real quick. And then let's look at it the next day. And if this is still in place, that's really a good sign that, hey, you know what? We got lymphedema already. Yeah, believe it or not. And that's a big drive home point, because a lot of people go, well, you sure it's not just the salt that she had? She had a whole bunch of popcorn. They had movie night. No, not in this case. Okay. And that's how an easy assessment tool that we can just do. Let's just watch it overnight and see how it acts the following day. All right, so I'll take my little detective hat off. Now what we're going to do is we're going to jump into the compression master form. And I'm just talking about this generically because I took different forms in the industry. Everybody's got their own form. You probably know that, okay? I just took the best of the best and I cut it all up and I put it in the slide so that way we can walk through a compression master form and we can hit everything that we need for our patient. Okay, so what we're going to do is the first box here on a typical form that we would use would be all the patient information. So the contact information for the patient. And then on the wound side of things, those of us that would be doing the wound assessment, we would identify, do we have a wound? Is it on the left or the right? That's what you see on that first page, on that first line. And then also, how many days of supplies are we going to need for this patient? Well, 30 days. I check that. We'd make sure that we have the ICT. I'm not going to screw around with 15. I got to go do it again. I mean, come on. We know what the real world is out there. So I'm clicking 30. I'm putting the right diagnosis code in because we always have to get it right. And then I'm also going to take the measurements of the limb that I'm talking about, the length, the width, the depth, and I'll explain how to do all that here in a second. We want to also hit the drainage amount. Is it partial or full thickness? And then has it been debrided or not? Now, there's some key things in this world that the patient needs to have some type of debridement. So we need to identify what type, was it debrided, yes or no? And then when was it? And then we would just put that date down in there. Also, wound drainage. Well, if there's no wound drainage, there's no coverage. I mean, that would make sense, right? There would always be some kind of drainage coming out of these for the most part. So these are just two key things that we want to keep on our radar. Okay, so step number one, identify where the wound is located. Is it on the patient's left or right? And it's always the patient. Just because I'm looking at the patient, it doesn't mean it's my left or right. It's the patient right or left. And the reason why I know it sounds so elementary, guys, people don't get that. They don't know it. They're facing the patient going, okay, well, it's on my right. It must be the patient's left or something, so let's make sure that we're identifying it correctly on the patient's right or left. And then this is how we would obtain the measurement. So we need to get the length, the width, and the depth. And when we are measuring a wound, I want you to measure a wound open edge to open edge. Okay. And people want to go outside the edge. And I'm like, no. You need to measure what is open. I mean, that's key. That's important. And we always should measure in centimeters, cm, not mm's, not inches. In this thing here for wounds, has to be cm's, okay? And some people say, well, what about centimeters? Is centimeters the same as centimeters? Yes. Just think of it, yes. In the wound care world, yeah. It just depends on where you are. Some people use different terminology, especially when you go out west, they call it something different. So centimeters always when we're documenting. Okay. And then this is just how you do it. Okay. Because there's 5 different ways to measure a wound, guys. And I just want to, the easiest way, the most consistent way in literature is the clock method. So this is a little exercise we're going to do. This is your patient's facing you. And what I want you to do is tattoo a clock on them. You see that? So the 12 is at the head, you got 6 at the feet. And so what you want to do is the greatest length from 12 to 6, the longest length. Okay, that would be your length. And then width would be 3 to 9. So that would be 3 to 9 for a clock. You want to get the greatest length, width from 3 to 9. And then I know people get messed up on the feet a lot. So when you have your patient and they're facing you, here, look at my foot. I brought a foot to the, I brought all my stuff, guys. So, but this is pretend your patient's facing you and they're in a ballerina pose, right? Okay. Well, where's your 12? Where's your 12? Your 12 is going to be at your heel, guys, at the heel, and your toes are going to be 6. So when your patient's facing you, I want you to think of them in a ballerina pose. And then you'll always get this correct, okay, on your length and your width. I know how it is. People get these flipped because maybe they're in the bed and patients in the bed and they're up lifting someone's limb and they're upside down with a little measuring device. And they're like, oh, and it's hot and it's heavy and it doesn't smell good. And they're like, oh, okay, that was 3 by 7. Oh, shoot, I forgot what my length was, what my width was. And they get all messed up. Don't get messed up. You think about that patient in a ballerina pose facing you. Toes are down. Heel is up. You're always going to get it right, 12 and 6, okay? All right, so that's how we would do the feet. All right, so now we're going to move to that other section of that master form. They want us to identify what kind of drainage we have, because we have to have drainage in order to get things covered, right? So exudate and drainage, they mean the same thing. It's tomato, guys. So whatever you guys want to use is fine with me. Whatever your protocol has, use that terminology. I tend to use drainage myself. So there are going to be times where you're looking at a wound and you're noticing that there is no drainage. It's so dry. Well, we know we're not going to get coverage on that for sure. But then, is it really dry? Really look into those tissues. Identify, is it dry or is it not? If it's dry, then it's really bone dry, and then we can't really help with that one. But a lot of times clinicians are really telling us, well, Nancy, it's an open active wound. And I look and it's the tissue's moist. And in this case, look inside that tissue. It's moist, right? So in this case, we could say scant amount. Okay, if we were describing the amount of drainage. Here we would have an example of some other wounds. Now here is where your detective techniques come in. Take that dressing off, but don't throw it in the garbage. I want you to look at that dressing. And how much is that dressing saturated? See that picture I have on that screen? If the dressing itself is saturated less than 25% of the bandage, like you see in that picture, then we use the word small or minimal. That's it. That's how we hit the amount of drainage. It's as simple as that. Okay. So if we took
let
off...
me interrupt you real quick, man. Sorry to interrupt you. This kind of falls right along what you're talking about there, and the measuring. A question came in. Some peri-wound are extended portions of the wound, and how do you account for these areas?
So remember when I said wound is open edge to open edge? If you've got something cooking in the peri-wound tissue area, that is a separate measurement. It's a separate assessment. And you can even use the clock on the peri-wound tissue. So you could say you have erythema, fancy word for redness, in the peri-wound space from 12 to 6 o'clock, measuring 3 centimeters. So you could say something like that, ladies and gentlemen. But it would be a separate standalone peri-wound measurement and assessment. Yeah, that's a good one, Josh.
Thank you.
Yeah. So, okay, we're good on this. We took the dressing off. It's saturated anywhere from 25 to 75% of the bandage. We're going to use the word moderate amount of drainage. That's how we're going to label this one. And then the next one is took the dressing off. It is saturated more than 75% of the dressing. Okay, now we're going to use the word large or copious. And I'm giving you generic words. Every form that you guys use might be different, and it's okay. I mean, as long as we know what the large amount is, the moderate amount, so we're documenting it appropriately. But that's how you do it. A lot of people just throw that dressing away, and then they're trying to figure out what the drainage is amount. There's no way you're going to figure that out if you don't have the evidence, the detective backup of that old dressing that was sitting there. So, okay, that's that. What else do we have? So here's another thing that we would need to put on the form. We need to identify if the tissue is partial or full thickness destruction. So here, the picture to the left is showing you partial thickness. To the right is showing you full thickness. I got a lot more pictures pictures to show you. So in order to be a partial thickness wound, what I want you to think about is the 3 Ps. This is just how I keep it straight in my head. It's always going to be pink. It's always going to be partial. And it's going to be painful because we have pain, we have nerve endings in that space. So partial thickness is epidermis is missing. There is destruction in the dermis, but you're not through the dermis, okay? So you're pink, you're partial, and you're painful. And that's what you have here. So here's another one. Epidermis is missing. Exposure to the dermis, but not through the dermis. You're pink, you're partial, and I'm sure that is very painful. Just a few more. Full thickness, different story, ladies and gentlemen. Okay, epidermis and dermis, you are through that already. You have blown through that already. Now you are in, at minimum, subcutaneous tissue. Okay, that's that fatty layer, adipose tissue. People call it different names, but that's where that is. And then you can also be down to the bone muscle joint. So it's the lower half there, okay, very deep. So this will involve possible muscle, bone, tendon, ligament, items like that. I have some more pictures of full thickness here. As you can see, you're going to see all kinds of stuff in here. This is not pink, partial, painful, and easy to figure out. This one's got all different colors, different structures in it. It could be yellow, it could be black, it could be brown, it could be green. When we start seeing colors and stuff like that, then it's full thickness. You could, you'd know it dead on. It's full thickness. So we would identify, is it good tissue or bad tissue? Viable tissue would be granulation tissue, means a tissue that's alive. Non-viable means that the tissue that was there has died, no blood supply, so it shriveled up and turned in a piece like shoe leather. That would be like a eschar. Slough would be something that is soft, string-like, kind of like a wet noodle kind of texture to it if you were to probe onto that. And like I said earlier, it could be any color. Multiple colors tells me that it's full thickness. And then lastly, when we look into these full thickness wounds, I want you to go on the hunt for muscle, bone, or tendon. Do we see any type of structures in these wounds? Look for these things, because that's going to tell you, again, where you're at, partial or full thickness. So a full thickness wound, how does a full thickness wound heal? Well, it heals from the bottom up. And we have this wonderful tissue called granulation tissue. And so granulation tissue will start to fill the hole, the wound, and it will go all the way up to the edge of the wound. And once it goes up to the edge of the wound, epithelialization will take place. So it's going to fill, it's going to cover, and that's how a full thickness wound is going to heal. This is not going to happen overnight. It's going to take time. It's going to take lots of interventions and somebody that knows what they're doing watching this wound so we can get it healed. This is a complex wound. So here's another box that I have on the form. Okay, so on our wound care supplies, based on our assessment, we can check off what type of supplies we need. So alginates, we know that absorbs drainage. Collagen, we put collagen on clean wounds so we can accelerate granulation tissue. So we have all the different products. We also have a column if you need AG on it or not. AG is silver, okay? It helps us with the antimicrobial side of things. And then we would also want to make sure that we include a frequency of how often we would change these items. That would make sense, right? And then we would check off what wound are we applying this to, and then any notes. So that's just one of the forms that is out there where you can capture all the stuff that you need to fix this wound with. And then this is just a pretty picture. This one I got from Josh. I love this picture because it kind of tells us where we gotta be when we're measuring a limb. So here's just another box. We're gonna click that diagnosis code because we know we need the diagnosis to cover everything. And then we need to prescribe the amount of compression, millimeters per mercury. So the physician would check off what they feel that they want, physician, nurse practitioner, whoever's prescriber. We would put the measurements in for the calf, the ankle, the length. And then lastly, we would decide, is it left or right extremity and exactly what they need. So we want to make sure that we're filling this order correctly.
Absolutely.
Okay. And then lastly, I know it's elementary, but make sure the physician signs the order. I know it just sounds so stupid, but it's just a lot of, they're not signing it, okay? So get them to sign it, make sure we have that documented. And then also, it's really nice to know who's filling out the form for the prescriber. It's not always the prescriber. We know the real world, right? So if it's somebody, I like to know, we always like to know who's filling that out. And that way we have everything documented, dated, and so on. Okay, so now I'm just going to go into the presentation of, here's where the big graphic pictures are going to come in, guys, okay? So these are just some things that we might see on both sides, CLT and the nursing wound care side. And this is hemosiderin staining. Hemosiderin staining on light-colored skin. So what this is red blood cells have leaked out into the tissue. It's up underneath the tissue. And on light-colored skin, it looks kind of like that rusty brown color that you see. Mm-hmm. Like they put a pair of dark socks on. Yeah, I mean, it looks like that, right? In the patient's right limb. Mm-hmm. So that's hemosiderin staining. We also see hemosiderin staining around wounds too. It can happen. Here's another condition that we might see with the patients that we serve, and this is called hyperkeratosis. Hyperkeratosis is an overproduction of keratin. And you can see layers and layers of that dry stuff, right? Mm-hmm. On the areas that they're hitting, so that the patient's walking around, they couldn't just get this laying in the bed. They're walking around, they're putting some force into it. And there's this overproduction of keratin that's going on due to the pressure. Cellulitis and dermatitis. I put this in because I see this common in these patients, but I want to break down the difference because a lot of people tend to interchange these words and they think it means the same and it really doesn't. Okay, so I just want to walk you through that. So here is an example of cellulitis. Itis, when you see that in the back end of these words, that means inflammation, infection. So in this case, patient has on the patient's left limb positive cellulitis. Mm-hmm. So we have an active spreading infection. Cellulitis is usually unilaterally, meaning one side only. In order to treat cellulitis, you got to treat it with antibiotics. You can't just let this thing go. It'll get worse, and the patient could, infections can take all the way to sepsis and can kill them. So we want to jump really quickly when we see something like this. Now, stasis dermatitis, well, that's a different story. Okay, stasis dermatitis affects both limbs. A lot of times we'll see it bilaterally on both limbs, but this is chronic inflammation that's just pretty much caused by stagnant fluids that's just sitting in the tissue. It's just sitting there. It's not infected. It doesn't need antibiotics. It certainly needs compression though. Mm-hmm. So if you're dealing with a wound that's in this site, we need compression in order to heal this wound. So just know that's stasis dermatitis. Okay. Did Josh tell you guys that you're going to have a quiz before we get done? Did he tell you that? I'm just teasing. That'll come later. That'll come later when we get together again. All right. So the treatment for chronic dermatitis, what do? Is they do cold compresses. They might choose to use topical steroids, maybe some ointments to help moisten up that dry skin that we're seeing. Because I see exerosis, right? Do you see xerosis? Mm-hmm. The dry skin. And then, of course, we need compression. Definitely need compression on this site. Okay, so here is an example of lymphorrhea. Lymphorrhea, you've heard of diarrhea, right? Okay, so diarrhea, we know that's running in a certain way. So with lymphorrhea, we've got lymph fluid, but that's running in its own way too. And this is kind of how it can show itself up. So this is high protein lymph fluid, and it just seeps and it just leaks through the surface of the tissue. And when you look at it, like when you first look at it really, really close with your, magnifying glass, it looks like a bead of just fluid that's just sitting on the skin. It's like, well, where'd that wetness come from? Do a little further investigation, you'll find out, oh my goodness, that's lymphorrhea. We got to get on this here. We need garments. We need somebody in here that knows what they're doing. This isn't right. We also can have lymphedema that is malignant. So these are just different types that we might see that's in our practice. But, to me, I've always said to my students, if the stuff, when we're looking at these wounds and looking at these sites and it looks funky, like this just doesn't look right, it doesn't look normal, well, then we need to further investigate. Is there, maybe we need to do a tissue biopsy and figure out what's going on. Could this possibly be cancer that we're dealing with? And here's just some other pictures of cancerous type lesions. They call this fungating wound. It has nothing to do with fungus. A lot of people want to match those two together. It's not. It's just they have cancer in their body and it shows up on the skin. And it could be anywhere. So it shows up on this gentleman's face. It could be on someone's heel. It could go anywhere. I've seen it on breasts before. I do want to tell you that these are highly odorous wounds. I mean, very, very stinky type wounds. If you look very closely, look at the nodules. You see that? So those are like cauliflower look to it. Notice it just doesn't look right. Again, if it doesn't look right and it doesn't look healthy, go figure out what's wrong with it. And let's run a test and see what's going on. But that's what that is. These are heavy bleeders too. So like if you're in home care and you're alone and you get one of these things to it starts bleeding. It's hard to stop the bleeding when these start bleeding.
Yeah. One question that just came in about the fungating wounds. Does compression help with discomfort, and is it safe to use on fungating wounds?
I'm not going to be the authority on that one.
I can't answer it either. It's a great question. I'm going to have to do some digging.
When it comes to cancer, there's different protocols. But number one is, as long as if we can identify that's number one. Let's identify it and then get it in the hands of a specialist, because I'm almost certain that the protocol is different in regards to that. Great question. Excellent question.
Yeah, I think, and other comments too are coming in. They're saying kind of the same thing. Like, I think it might be case to case, that kind of thing. I'll do a little research. I've written that one down, and we'll see what kind of studies that are out there, and we'll help you find the answer for sure. Thank you for that.
Can always do a part 2, Josh.
Yeah. Right. Yeah. There we go. Maybe that's the part 2.
Just on the questions, that we're getting.
Yeah.
Okay. Right. So here's something else. This is like showing you fibrotic changes that you might see in the limb. And some people might say, oh, that almost looks like a bowling pin, upside down bowling pin, upside down champagne bottle, whatever the case may be. When we see that, that's fibrotic changes that took place. Yeah. Okay, just some more different pictures to show you. We'll see brawny edema, lipodermatosclerosis, that's a mouthful. And let's see here. Okay, here is it's a mouthful. Let's break it down. Lipodermatosclerosis, that's what this is. So this is where you have a condition that's kind of overlapping with venous insufficiency and lymphedema kind of coming together there. So how you break the word down, lipo is fat, dermato is skin, sclerosis is hardening, and then inverted champagne bottle, like we discussed earlier. That's what this is. And then here's another condition that we'll see. It's lumpy skin, wart-like projections, cobblestone looking. And this is due to dilated lymphatic vessels. And what it does is these actually collect lymph fluid. And that's why you see this over-exaggeration look here. So identifying lymphedema, venous compression no longer is adequate. Okay. So what this is kind of driving home what we just talked about. How do I know I have lymphedema? Well, venous compression is not working any longer. CDT is needed. We're starting to see fibrotic changes in the tissue. Manual lymph drainage is necessary. Compression is necessary. We do a stemmer sign. This is an assessment where, okay, we have 2 limbs here on the patient. Notice how they're pinching at the base of the second toe. Okay, so on the left of it, notice that when they pinch, their fingers aren't coming together. Okay, and on the other toe, their fingers are coming together. So So that is a positive stemmer sign, which would be on the left one, and there's nothing wrong on the right one. Okay, but that's a quick look, a quick assessment thing that you can do really quickly is like, you know what, let me just check and see what that stemmer sign is going to look like. And that's all they have to do is just pinch it right there at the base. Here's a couple other things I have left to just show you. We'll see this in abdominal folds, skin on skin contact. This is called intertriginous or intertrigo if you want to shorten it. It's a skin inflammatory process that takes place. So it could be under the arms, in the abdominal folds. And what happens is in these folds is it'll trap moisture, and then it has a little friction because the skin is moving, and then we have breakdown. So here we have folds on this patient, right? And so they're lifting one fold, and notice the top fold matches the bottom fold, almost like a mirror effect. And that is a classic sign of intertrigo. It tends to take the shape. It's a linear shape, and the damage on the skin itself will tend to be just partial thickness. These are not full thickness type wounds. And so when you look at the wound bed, it might be moist, oozing a little bit, might have some crustiness, but this would be very typical of intertrigo. This is on darker skin. Notice it's darker skin in the affected area when you're comparing it to the surrounding skin. And that's how you can kind of zone in on that. And what happens when this is going on for a while and no one's helping this patient, it'll start to get some itchy and burning in between the folds. Sometimes it might pick up an odor, hygiene kind of issue, kind of smell that you would pick up. But this is what happens when it goes so far. Now we are infected with some type of bacteria, okay? Now we have true demarcation lines. You see that? You see the line where the good skin starts and the bad skin starts? Okay, demarcation, that's what that is. And you'll see it on dark skin and light skin. And this is just, who's at risk tends to be people that are in warm climates, that are overweight, they have lots of body folds, they have diabetes. Those are the folks that tend to have this skin condition. Again, just a few more pictures. And then sometimes the folds will pick up yeast. So it's not the bacteria, it's now yeast. And with yeast, you can smell yeast. Like if anyone smelled baking bread in a kitchen, it has that yeast smell. That's exactly what this smells like. And it's aggravated by heat, moisture, uncleanliness, lack of air circulation. Our patients with cancer have it. Our patients that have lots of antibiotic use, they will tend to get yeast. Candidiasis is the fancy name. And here we go. Sometimes you might have like a little pustule sitting by itself, and people will see it and go, oh, maybe they just need some lotion. And they put lotion on it and it just flares up really, really red and angry. It's yeast. That's how yeast acts. We treat it with antifungal cream or powder. We knock this thing out within a few days. As long as we know what it is, we can fix it. It's really easy to fix. And now we're at the end. So I got some gifts for you guys. Okay, so here is a free lymphedema guide. I designed this. I put the stages of lymphedema and some different definitions that we talked about today. So shoot the QR code to download this for free. And then let's see here. Okay, oops, and then next. Okay, and I don't want you to forget about this micro-credential. It's the first one in the world that was ever created, and I want you part of this. I want you to be part of this first group of people. So shoot the QR code. We will notify you when we go live. It'll be sometime in March. We're not far from it. And let's see here. Oh, and then don't forget, those of you that need the CEs, okay, these are your course evaluations. Shoot the QR code, fill out the evaluation form, and then a CE will be sent to your email directly. And I think that's it. Now we're at questions, Josh. I'll leave that up.
Yeah, so let's see. We kind of answered them as we went.
Okay, then.
Hold on a second. I think the initial QR code on the previous slide went to the overall website. So one of the QR codes may not have been functioning right. At least that's what I'm seeing a report to. But I'm going to give you guys one of the things that can you shoot the first, will you go back to the first QR code real quick? Someone's asking for that. We'll jump back a little bit, but I don't want anyone to
That one.
stress out
Uh-huh.
on these. I think, yeah, that one there. I don't want
I'll
anybody to
try.
stress out on these because we are going to be sending out some follow up. We're going to be following up with some of these, and I'm going to get you all of these QR codes and or at least links sent out in your email to anyone that's on here and intended here. I also dropped a link in the chat there that is for a Teams meeting. We are hosting a lounge all day long. That lounge, anybody wants to jump in. Nancy, if you have a few minutes left in your day, I know you run busy all the time, but if you do have a few minutes and you'd like to jump over there as well, you're welcome to jump over there. I've
Sure.
got team members standing in there, hanging out all day long today. They've been rotating in and out and just talking to people and chatting and answering questions. You're welcome to continue the conversation over there. But we will get you, Yolanda, everybody that's mentioning this. I've seen a few people, but we will get you email versions to every single person on here of all of these websites so that you get every single one of those QR codes so that you can get the CEs. I can't promise that I'll have them out today, but I will definitely get them out
Yep.
in the next days.
Just real quick, Josh. So I did shoot this, guys, and you do go to my page on my website. But all you do is you go to click the lymphedema one and use the code Big Day 2026 when you do the checkout, and it won't charge you, and you can download it for free. So just work the magic once you get on there. Okay. All right. Good.
And we'll make sure that you have everything. Anything you don't have, feel free to reach out to me. It's joshua@compressioncare.com. Anything at all that you'll need, reach out. You will never bother me. I promise you that. And thank you all for being here. Nancy, thank you so much for doing this. We really do appreciate you being part of this. Basically our keynote speaker today. So thank you so much
Thank you,
for
guys.
being right here at the noon hour. So I do appreciate it. CEs I think they will go both OTs and PTs as well. Is that correct, Nancy? It's not just practitioners, but OTs and PTs will be fine with the CEs if they report them to their accrediting
Oh,
body.
that's true. Yeah. Many can just take it and then they report it to their own authorities. Yeah. You're right.
Should be absolutely fine there.
Mhm.
We'll get everybody that's asking, I will get emailed out to every single one of you. Will get the QR codes so that you can get on there, and you'll have that in the next day or so. So thank you so much for being here. I promise we'll get you everything you need. Nancy, thank you so much. I really do appreciate it. Y'all have a great day. If you're joining us for the later segments, I will see you here in about an hour. Everyone else, thank you so much for being here and have a great rest of your day. Bye bye.
Bye.